31st, 2022. My name is Akmal Ferezi, and I will be your host for today's lecture. I would like to welcome all participants, especially our supervisor, all anesthesiologists from around Indonesia and abroad, my senior and fellow resident, and all other audience. This event is held by Study Program of Anestesiologi and Intensive Care of Universitas Sumatera Utara. Today, we are honored to be joined by Dr. Mary Suma Cardosa. Dr. Mary Suma Cardosa is from Malaysia and the President of Malaysian Association for Study of Pain. Thank you, Dr. Mary. Despite having a busy schedule, you can still spare some of your time to share some of your knowledge and experience with us today. And I would like to greet Dr. Andrea Muri, Spesialis Anestesiologi, Intensive Care Consultant, as the Head of Study Program of Anestesiologi and Intensive Care of Universitas Sumatera Utara. For today's lecture, we will listen to the national anthem of Indonesia, Indonesia Raya first. Please stand up straight to listen to our national anthem. All right, thank you. And now, for the next agenda, we will hear the opening greeting from Dr. Andrea Muri, Specialist Anesthesiologist, Intensive Care Consultant as the Head of Study Program of Anesthesiology. For Dr. Andrea Muri, please, the time is yours. Thank you.
Okay, thank you, Dr. Akmal. Good afternoon to our dear speaker, Dr. Mary Suma Cardosa from Malaysia, and also the President of the Malaysia Association for the Study of Pain and all participants in this webinar. It's such an honor for our study program of Anestesiologi and Intensive Care Medical Faculty of Universitas Sumatera Utara to have such a great speaker. As we know, pain is the fifth vital sign and also division of anesthesiology and intensive care. As an anesthesiologist, we must be able to provide prompt and appropriate services to monitor pain, treat pain, and provide therapy for acute and chronic pain management. Therefore, we invite Dr. Mary Suma Cardosa to provide us updated knowledge about the management of acute pain, especially post-operative pain, so that we can decrease the morbidity of pain patient and the length of stay in hospital. Finally, we can improve health services in post-operative pain management generally in Indonesia, especially in North Sumatra. And today, we are having an international guest lecture with the topic current update of post-operative pain management, as the main idea of this presentation is that we could contribute to give a better quality of post-operative management. Last but not least, I would like to thank to Dr. Mary Suma Cardosa for your willingness to deliver the knowledge to us. And we are waiting for another opportunity to have you as our source person in the second North Sumatra Conference on Emergency, Anesthesia and Critical Care, which we held on March 2023 in Medan, North Sumatra, Indonesia. Thank you for your kindly, Dr. Mary Cardosa.
All right, thank you, Dr. Andre Muri, for such a warm greeting. Now we will continue to our main agenda, that is the lecture itself. The lecture will be led by Dr. Rico Gandhi as the moderator. Dr. Gandhi, please, time is yours.
Thank you, Dr. Akmal. And I will take it from here now. Good afternoon, ladies and gentlemen. Welcome to International Guest Lecture held by Study Program of Anestesiology and Intensive Care, Medical Faculty of University of Sumatera Utara. I am Rico Gandhi, and I'm going to be your moderator today. We have the speaker of this lecture today who are already with us, the Honorable Dr. Mary Suma Cardosa. Hello, Doctor. Thank you for sparing your time, Doctor, to be with us today. I hope you are well, wherever you are right now. And I'd like to greet Dr. Andrea Muri Prima Putra Rubis, Magister of Anestesiology, Anestesiology Specialist, Intensive Care Consultant, as the Head of Study Program of Anestesiology and Intensive Care, Medical Faculty of University of Sumatera Utara, who make this lecture possible, and all of our audience who are already present in this meeting. Ladies and gentlemen, the topic for today's lecture is about current update of post-operative pain management. The topic will be presented by Dr. Mary for around 40 minutes. And after that, we'll have discussion session for about 20 minutes. During the presentation, you can ask in the chat box and don't forget to mention your name and institution. And for your information, our audience are vary from anesthesiologists, residents, and researchers, and also students from all around Indonesia. Now, first of all, let me introduce our honorable speaker today, Dr. Mary Suma Cardosa. Before Dr. Mary Cardosa make her presentation, I will read Dr. Mary curriculum vitae. Dr. Mary Cardosa was a consultant of pain specialist with a specialty in pain management, working in Park City Medical Center. And Dr. Mary Cardosa worked as developing pain services in Malaysia and as implementation of the pain-free programs in the Malaysian Ministry of Health. For the personal qualification, Dr. Mary Cardosa was a consultant anesthesiologist and pain specialist at Hospital Selayang, Selangor, Malaysia. And currently, Dr. Mary Cardosa also acts as a president of the Malaysian Association of Study of Pain, MASP, SP, and as council member of International Association of the Study of Pain, EASP, for 8 years, now serving as a secretary for the last 2 years. Dr. Mary Cardosa was also the secretary of the Association of the Southeast Asian Pain Societies, ACAAPS. And now, without further ado, please welcome Dr. Mary Cardosa to make her presentation. Dr. Mary Cardosa, the time is yours.
Thank you very much, Dr. Rico, and thank you, Dr. Andrea Muri, for that very kind, warm welcome. Thank you for inviting me to give this lecture. I wasn't very sure about how to pitch it because I think if there's students and there is residents and maybe a few consultants, the range of knowledge will be very wide. So I try to make it more general. So I will start sharing my slides in a minute after I switch on my timer. Okay. Okay, wait. Share screen. You have to tell me whether the slides,
Okay, we can see the slide.
you can see? Okay, is it, you can see the title?
Yes,
Okay,
you can see the title, Doctor.
is it moving?
Can you press the next slide, please?
See, this is always the problem.
It's still not moving, Doctor.
It's not moving, okay. I have to use another, I stopped the sharing. It's always, I'm not very sure why this happens, but I have a backup plan. Okay, I try again.
Okay, Doctor.
Sorry about
Take
that.
your time.
We didn't have time to practice.
No problem, Doctor.
Keynote. Okay, this one. Can you see the?
Yes, we can see the slide, Doctor.
But let me see how to make it bigger. Okay.
Okay.
You can see the slide. Now, can you see the next slide?
Yes, we can.
Okay.
We can see the next slide. Okay.
So this is what I will talk about in hopefully about 40-45 minutes. Some basic concepts first. Definition of pain, of course, we have to talk about that all the time. And then I'll talk about some general principles of management when we talk about management of acute postoperative pain. I will talk about treatment options, multimodal analgesia, and some specific techniques, which I will not go too much into detail. And then talk about some guidelines, what are the safety considerations, and then before I summarize. Okay, so the definition of pain, we all know that pain has been defined as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue injury. Now, this definition has been there since the 1970s, but has recently been revised. Previously, it said that it was an unpleasant sensory and emotional experience associated with tissue damage, tissue injury, or described in terms of tissue injury. They've taken out the word described because they want this to also apply to non-verbal humans as well as non-human specimens like animals, because we always do our experiments on pain in animals. So they have widened it a little bit, but the essential thing is the same, that pain is unpleasant, it's a sensation, but there's also an emotional component. It's an experience, so it's very individualized. So we must always remember this when we are treating patients with pain, whether they have acute pain or chronic pain. We still must remember that they are individuals and each person experiences pain differently. So for us, focusing on acute pain today, acute pain is always associated with tissue injury. And in fact, it is much easier to manage compared to chronic pain where the tissues have already healed and there's no more tissue injury. So this definition includes both acute as well as chronic pain. So as I mentioned just now, you have acute pain and we have chronic pain, and both pain can be nociceptive, neuropathic, and there's one more class which we have added to chronic pain, which is nociplastic, which I didn't put in this slide, sorry. But we are focusing today on acute pain. So acute pain usually is due to tissue injury. So it can be trauma, can be surgical, and today we are going to focus on post-operative pain. So the tissue injury is from the surgeon's knife. Okay, after the tissues heal, the pain goes away. So this is very important, that acute pain is always short-term, and acute post-operative pain is usually, in the majority of cases, short-term, goes away when the tissues heal. However, you have such a thing as post-surgical syndromes, where even after the tissues heal, the pain continues. And so acute pain can become chronic. Okay, there's also other types of chronic pain, which we are not going to talk about today, where there's no particular injury, is what we call an insidious onset. But we're not going to focus on that today. Okay, so we are focusing on acute pain today. So it's the pain that everybody has experienced. There's nobody in this world really who, except, you know, a very small number of people who have a congenital abnormality, which I'm not going to talk about, but pain is something that all of us have experienced, whether we have, injured our finger in the, smash our finger in the car door, or whether we've fallen down and sprained our ankle, or whether we have had surgery, or even giving birth to a child. That is all acute pain. It's associated with tissue injury. And importantly, as I mentioned before, it goes away when the tissues heal. So this is very important, because when you treat acute pain, remember that your treatment is short-term. So you can be very aggressive with your treatment because it is short-term. Acute pain has a protective role and an adaptive role. So it's good. It is actually good for us, because if we did not have pain, the ability to feel pain, all of us would have lots of injuries, and we wouldn't protect ourselves and allow the tissues to heal. Okay. Chronic pain, on the other hand, is pain that persists even after the healing has taken place, or there's no particular tissue damage. And that's why the term resembling that associated with tissue injury is included in the definition. But that's all I'm going to say about chronic pain. So we have to know this a little bit about the pain pathway. How do pain signals get to the brain? Actually, we know that we feel pain in the brain, right? If the good news about having pain is that you have a brain, but usually when we tell patients that, they are not very amused. But anyway, so pain starts at the periphery and you feel it in the brain. And what happens? You have a noxious stimulus, whether it's heat, chemical, cold, or trauma, pressure. This noxious stimulus is then translated by transduction into an electrical signal, which is then conducted along the neuron. So this noxious stimulus will stimulate the nerve endings, the free nerve endings in the periphery. Then the signal, electrical signal, is conducted along the nerve nociceptive fiber. Okay, and we know we have two types of nociceptive fibers, the A delta and the C fibers. And we don't have time to go into that. It comes into the spinal cord through the dorsal root, synapses in the dorsal horn, crosses over to the other side, and goes up the spinal thalamic tract to the brain. Okay, so this is something that you need to know for exams, and you also need to know because you need to understand that there are many places along the whole pain pathway where you can modulate or modify or block the pain signals. Okay, so you have this whole thing. So we can block it at the periphery, we can block it at the nerve, we can block it at the spinal cord, or we can block it at the brain. At the brain, you have the somatosensory cortex where we localize the pain. Is it in the leg? Is it in the tummy? Is it in the head? And it also goes, so at the brain, it synapses in the thalamus, then it goes to somatosensory cortex, it goes to the limbic system, which is the emotional and the memory part of the pain. And it also goes to the brainstem, which then generate the automatic responses like increase in heart rate, increase in blood pressure, and so on and so forth. Importantly, our brain also can send down descending signals, send signals back down to the spinal cord to modulate the pain signals, to modify the pain signals. And we make use of this much more in chronic pain management, but we can also use it in acute pain management in our non-pharmacological techniques, or nowadays getting more popular, the use of what we call adjuvant analgesics to try to reduce the use of opioids, which are really the gold standard for the management of acute pain. So that's the pain pathway. Okay, and in terms of post-surgical pain, really what we are looking at is an inflammatory response due to tissue injury. The tissues have been cut, and so noxious chemicals have been released, which then start this cascade. We also have to remember that what I showed you just now is the pain pathway or the nociceptive pathway, which involves nociceptive fibers. But nociception and pain are not the same. Nociception is that process of transduction, conduction, transmission of pain signals to the brain, but pain is actually what the patient feels. Okay, and remember that what the patient feels is modulated, modified by their beliefs and concerns about pain, some psychological factors, their mood, whether they're angry, depressed, or anxious, some cultural issues, social factors, how do family respond to them, and their coping strategies, and other illnesses that they have. So all this actually will modify the patient's experience of pain, and the patient is the one who has to be treated, not the nociception, right? Although in acute pain, we focus really on nociception, but we need to understand this biopsychosocial model of pain, which means that each individual patient experiences pain differently, even though they may have exactly the same surgery. So somebody after knee surgery, TKR, for example, may feel very little pain. Another person may have a lot of pain and a lot of disability. So it varies because of this whole biopsychosocial understanding of pain. That's how we can understand what is going on. The other thing that we need to also know about pain is that there are different mechanisms. The pain can be nociceptive, and most of post-operative pain is nociceptive, but there's also, which is described typically as sharp or dull or aching or but we also have different types of pain, which is due to nerve injury called neuropathic pain. And there's a third type of pain based on mechanism, which is called nociplastic pain. So very quickly, I'll just go through. So nociceptive pain is pain that arises from actual or threatened damage to non-neural tissues and is due to activation of the nociceptor fibers that I talked about just now. And it occurs in a normally functioning somatosensory system related to injury. And this is what we call physiological pain. And this is really what we have to focus on treating when we treat postoperative pain. However, and there are causes, so surgery and trauma, and that's what we're going to focus on, but it can also be chronic, like in any kinds of arthritis and mechanical back pain. Then we have neuropathic pain, that is pain that is caused by lesion or disease of the somatosensory system. And described differently. Usually they will say it's burning, shooting, stabbing, and sometimes spontaneous pain rather than made worse on movement, which is nociceptive pain is always worse on movement. So you see your post-surgical patient lying still in bed and saying, I have no pain, but the minute you ask them to get up or to take a deep breath, they have severe pain because it's worse. Nociceptive pain is worse on movement, but neuropathic pain can come spontaneously. And this is what we call pathological pain. Okay, usually chronic, but it can be acute. So sometimes if you have nerve injury related to trauma, the patient after the surgery can complain of pain that is not relieved by your usual analgesic medications like morphine and NSAIDs. Okay, so you wonder why this patient is a bit crazy. I've given him so much medication and yet still complaining of pain. you need to find out what that pain feels like, because it could be acute neuropathic pain, which you need to treat using different agents. And I'm really not going to have time to cover this in this talk. So neuropathic pain can be central or peripheral. I'm not going to go into that. Nociplastic pain is a new concept that we have been talking about for the last 5 years or so, and it arises from altered nociception despite no evidence of actual or threatened tissue damage. So cases like fibromyalgia, you cannot find anything wrong in the scans, the MRIs, the X-rays are all normal, but the patient has pain. There's no nerve injury, but the patient has pain. You know, things like irritable bowel syndrome, where they have abdominal pain, but you cannot find, they do numerous surgery, but cannot find anything wrong. All this is what we call nociplastic pain. Again, we are not going to talk about this, but you just need to know the whole spectrum of different types of pain so that you can identify the type of pain when you assess a patient with pain, even if it's post-operative pain. Okay, so now we're going to talk about principles of management. Before I go into that, we must know that, in fact, even though I said that post-operative pain is easy to treat, a lot of patients report that their post-op pain is not well treated, which is very sad because it is actually something that we can do. So there are many studies that show that it's not well treated. Okay, and in Malaysia, we did our own study and we found that 65% of our patients have 35% of our patients have moderate to severe pain. So that's quite a large number, you know. Only 65% have good pain control, but we still have 30% who have poor pain control. And in some studies, there's much higher figure. Okay, the other thing that's important to know is that if you don't treat acute pain properly, you can have lots of physiological consequences, which is short-term. Okay, so you can have increased sympathetic activity, giving rise to increase in blood pressure and tachycardia, which can strain your myocardium, your heart. You have GI effects, you have shallow breathing because you cannot take a deep breath because of pain. Okay, increased catabolic demands, you have anxiety and fear, and you have something called sensitization. And it is this that, in fact, we are most concerned about, because with this peripheral as well, especially with central sensitization. Okay, if you want to discuss the concept of sensitization, we can do that later. But patients who don't have acute pain properly treated are at a higher risk of developing chronic pain. And that's why in the earlier slide, I showed you that there are certain percentage of patients who can develop chronic post-surgical pain. So I believe that as anesthetists, it is really our duty to treat acute pain well, although of course it's the surgeon who causes the pain, but you know, we are always the ones who look after the patient, isn't it? You look after the patient very well during the surgical period, and then after that they go back and they have pain in the ward, and if you don't treat that pain properly, they are at a higher risk of developing chronic pain, you know, which will affect them for the rest of their life. You know, so I think we have a very important role to play in relieving acute postoperative pain. So my take on acute pain is that it should be aggressively treated so that the patient is comfortable and has a good experience in the hospital, so that the patient has less adverse physiological effects like increased blood pressure, increased strain on the heart, collapse of the lung and infections, so that the patient has less psychological consequences and doesn't fear further surgery, for example, anxiety, and so on and so forth. And importantly, as I mentioned, to reduce the risk of developing chronic pain. So we need to treat aggressively because it is very important for the future of the patient, but also because our treatment is really only needs to be for a short period of time. I always like to use this model to show in any kind of pain, we need to use a multidisciplinary, multimodal approach. So multidisciplinary means not just doctors or anesthesiologists involved, but also surgeons. The surgeon has a role to play, the nurses, the physiotherapists, the who else is in the ward? The pharmacists, everybody has a role to play in the management of all patients with pain. It seems to be more sort of fashionable or more utilize this concept of multidisciplinary management in the management of chronic pain, but I believe that in acute pain, it also makes your management more effective. And the other term, multi, is multimodal. That means more than one type of pain method to control the pain. So not just drugs or not just physical methods, but a combination of methods, which you can see here. But it all starts with good assessment, because you need to assess the patient in order to know what are the appropriate treatments. So you can use drugs. Surgery, of course, may be the treatment for pain. Like, for example, if the pain is due to acute appendicitis, you need to take the appendix out. You need physical methods. You need occupational therapy sometimes. You may need some nerve blocks. You can use some traditional methods and psychological therapy. And all these are the different methods we use to treat any kind of pain, whether it's acute or chronic. Okay, for acute pain, we focus on drugs. Physical therapy are more passive, like hot and cold pack or immobilization, for example. Okay, but whatever it is, our aim overall is that the patient improves in function. And for the chronic patient, we want to improve their quality of life also. But even for the acute post-surgical patient, we want them to be able to get up, go back home to their family, and go back to work as soon as possible. Okay. So what are the principles of acute pain management? First, assessment, right? So you have to assess, and the simplest way of assessing, you need to look at the cause, the site, intensity of pain, and to know about what kind of pain it is, okay, and the type of pain. I didn't put type here, sorry. So we use this simple thing, PAIN. So P for place, where is it? A for aggravating factors, what makes the pain worse? I for intensity, how bad is the pain, or what is the pain score? And N for nature, what does the pain feel like? And neutralizing factors, what makes the pain better? So after asking these few questions, you will know the type of pain, whether it's nociceptive or neuropathic or nociplastic, okay, and whether it is acute or chronic. Okay, so I put here, and also you need to know how has this pain affected the patient. And in acute post-operative situation, you're really looking at whether the patient can breathe deeply, whether the patient can get up and go to the toilet, and so on and so forth. A physical, mobilization rather than anything else. But obviously in chronic pain patients, you look at more than that. You look at work and family and so on and so forth. But here, the assessment is important because we want to know whether the patient has pain and the level of pain and what we need to do to treat the pain. So pain has been called the fifth vital sign. I'm sure you have heard of it, and now the fifth vital sign has become a bit of a bad word in the USA because of their opioid crisis, which I don't really have time to talk about, but if you all want to discuss that in the discussion, we can do so later. Okay, so pain is the fifth vital sign. So the four vital signs, respiratory rate, pulse, blood pressure, and temperature, are things that the nurses do all the time. But in 2001, the USA, in fact, the American Pain Association, American Pain Society advocated for pain to be recognized as the fifth vital sign. And in Malaysia, our Ministry of Health adopted pain as the fifth vital sign in 2008. So it is supposed to be assessed every time the other four vital signs are taken. Why? Because you cannot see pain, so you have to ask the patient whether they have pain and how much pain they have. I'm not going to go into pain scales because I'm sure all of you know about it. And the commonly used pain scale, obviously, is the numerical rating scale, which is 0 to 10, where 0 is no pain at all and 10 is the worst pain that you can imagine. But I'm not going to talk about that at all. But we do need in acute pain to assess the level of pain. And then after you have treated the patient, you need to reassess to know whether the pain score has come down or not. So when you manage acute pain, you can use non-pharmacological as well as pharmacological techniques. Okay, and the non-drug techniques I'll talk about a little bit afterwards, a little bit more afterwards, but they're physical as well as psychological. And of course, surgery is also there, as I mentioned earlier. Then you have medications and you have what we call analgesic drugs, simple analgesics like paracetamol, you have NSAIDs and COX-2 inhibitors, and you have opioids. And then we also have the adjuvants nowadays getting more popular. I will just mention it later on in my talk, but it's not become, I believe, a routine part, although some anesthetists do use these other adjuvant drugs routinely. You can also use local anesthetics via central neuraxial blocks or peripheral nerve blocks. And I'll just mention all these later in the different techniques. Importantly, whatever you manage, you need to reassess. You need to go back to the patient in a timely manner. Don't wait until tomorrow. If the patient is having a pain score of 8 or 9 or 10, and you are treating the patient, you need to reassess the patient after you give the patient whatever it is, morphine, or you give an epidural, or whatever you give the patient, you need to reassess the patient to see whether your analgesia is working or not. And you need to do it within the period of time that you expect your analgesic technique to work. Okay, so if you're giving morphine, IV, within a few minutes, you can actually ask the patient again for a pain score and see whether you need to give more morphine. And we anesthetists, we are very good at titrating drugs, okay? So we have what we call the morphine pain protocol, where you give 1 milligram or 2 milligrams, or sometimes 0.5 milligram, depending on the age of the patient, to the patient with a high pain score. And you can do this in the recovery room. And then you take a pain score, you do the vital signs, the other vital signs as well, including respiratory rate, and you give the morphine. After that, you reassess after 5 minutes, and you can keep doing this every 5 minutes until the pain score comes down to a comfort level. And usually we consider comfortable as a pain score of 3, okay, or no more than 3, which is mild pain. So morphine, as I've mentioned a few times, is the gold standard when it comes to acute pain management. I mentioned assessment and reassessment and documentation. So you document the pain score before, you document the pain score after you have given the analgesic, and you also document your vital signs, your other vital signs, respiratory rate, usually blood pressure and pulse, not so much affected, but importantly, respiratory rate. Okay. Pain that's established and severe is difficult to control, so don't let the pain become severe. Monitor the patient and treat when it is moderate rather than when it is severe. Okay, so we talk about preventive analgesia, prevent the pain from getting so bad rather than preemptive analgesia. Treatment must be individualized. As I mentioned, it is an individual experience, and therefore your treatment should be individualized, and you should plan it pre-operatively and discuss with the patient as well as the surgeon maybe. Okay, especially if you're using regional anesthesia. Okay, the aim of good pain management is to reduce pain to a tolerable level, so 3 or less, not to eliminate to 0 completely. Okay, if that is your aim, you may overdose the patient. And you need to use a multidisciplinary approach, which has been shown to have better outcomes. Utilizing your nurse, your physiotherapist, your pharmacist, and the other doctors who are managing the patient. Everybody has to have the same goal. And sometimes, you know, when we do our acute pain rounds, we have a bit of a disagreement with the surgeon, and that's not very good. You know, if you really need to get the surgeon on board, and the surgeon needs to understand what you're doing and why you're doing it. Monitoring is important because you don't want to give the patient good pain relief, but knock the patient out, right? You know, or cause complications like respiratory depression. So you need to monitor. And the reason why one of the big roles of having an acute pain service to manage post-operative pain is so that the APS can set up routine monitoring and train the ward nurses to do it, and when to call for help so that you can go and see the patient and prevent any adverse outcome. The other concept that we need to know about is multimodal analgesia. So we need to use more than one type of drug and more than one route of administration, maybe, to improve efficacy and reduce side effect of each of these drugs. Importantly, our overall aim of acute pain management is restoration of function. So return to work, go back home. There was a recent paper talking about the psychosocial factors. So this studied the independent effects of depression, anxiety, and pain catastrophizing on pain outcomes. And even with acute post-op pain, there was found to be a benefit of improvement in pain outcomes when you can address some of these anxiety, depression issues before the surgery. So what are the different treatments that we have? I've listed it here, and actually I don't know whether I have time to go into detail. I'm already at 30 minutes. So I'm going to zoom through. Okay, so you have oral analgesic, of course, but if you have major surgery and patient is nailed by mouth, you cannot use oral. But if you have orthopedic surgery, you can use oral analgesics, you know, and you can use paracetamol, NSAIDs, coxips, and opioids. All of them are available in oral form. Then you have parenteral, subcute, and IV morphine, which can be administered by the nurse or by the doctor, which the doctor won't do, usually by the nurse intermittently. But nowadays we have these nice machines that allow us to use patient-controlled analgesia, which gives you better control of the post-op pain because the patient is the one who is controlling it. Then you have blocks, neuraxial, as well as nerve or plexus blocks, and you can use some of these together. Okay, so there are different drugs that we can use to treat pain. And here, the main one for acute pain are opioids, paracetamol, and NSAIDs or coxips, as well as local anesthetic. These are what we call the adjuvants, the anticonvulsants, antidepressant. Then you have ketamine, clonidine, baclofen, and other such drugs. And lignocaine given parenterally, which can also be used. And all these drugs really are to reduce pain and improve function. Okay, remember that all drugs also have side effects, so you may have to use drugs like metoclopramide to reduce the side effect of vomiting from opioids, for example. Okay, the ideal, never mind about this. Okay, so we talked about multimodal or balanced analgesia, where you use opioids together with other drugs in order to improve analgesia, reduce the dose of each analgesic, and therefore reduce severity of side effects and improve overall outcomes. You need to know where the different drugs work. So this is a very complicated slide, but it shows you that, you know, going back to the pain pathway, different drugs work at different parts of the pathway. So NSAIDs and COXIPs work at the periphery, local anesthetics work to reduce transmission, okay? And then opioids work at the spinal cord and the brain. Okay, I don't have time to go into a lot of detail, but using drugs from different classes together, you can have also an improved, enhanced function because you are attacking the pain pathway at the periphery, at the spinal cord, and at the brain, for example. Okay. So multimodal analgesia, our standard analgesic regime actually for post-op pain is opioid. I said morphine is the gold standard, but we can add in paracetamol. If the patient's taking orally, you can use oral. If not, you can use IV paracetamol, which is quite expensive, but has a role to play. You can use NSAIDs and COXIPs, again, orally, but you have parenteral forms as well. And you can use regional blocks. So usually we use a combination, not just opioids alone, but always there's something else, okay? The combination analgesic regime depends on severity of pain, type of surgery, site of surgery, of course, and patient comorbidities for contraindications. For example, if the patient has renal impairment, you cannot use NSAIDs or COX-2 inhibitors. And then apart from the standard analgesics, other drugs may also be used like ketamine, lignocaine, gabapentinoids in specific indications. And now gabapentinoids more and more like pregabalin and gabapentin used more and more to reduce the consumption of morphine, which has been shown to reduce the consumption of morphine in the immediate post-op period. But the real aim of people using these drugs was to prevent the chronic post-surgical pain, and that hasn't really been found definitely to reduce the use. And the problem with the gabapentinoids is we really don't know when to start, how long to give, and what dose to give it at. And they make the patient very sleepy, and you really don't want a patient to be sleepy in the post-operative period because you want them to be doing their breathing, their movement, and so on and so forth. So I showed this slide because I wanted to show you that as far back as 1997, Henry Kellett has already advocated the use of multimodal, not just drugs, but other techniques, exercise, nutrition, reduction of stress, and so on and so forth for the control of post-operative pain. Today, we have more complicated with the onset of this thing called ERAS, Enhanced and Recovery After Surgery, and anesthetists are always in discussion with surgeons about how to get their patients up and about faster. And with the interest in day surgery, also this has become more important. Again, don't have time to go into detail, but there's more and more interest. And one of the problems with this is that they see morphine as a bad guy, because morphine causes ileus, morphine causes drowsiness, morphine causes nausea, vomiting as side effects. And these may prevent the patient from getting up and going home early. Okay, so people have been trying to look at opioid-free analgesia, which I personally don't believe is such a good thing. I think that we should be using other methods and drugs to reduce the amount of morphine that we give to the patient, that the patient requires, but I don't think we should be giving zero opioids. I think that that is a bit silly. But, you know, there are anesthetists who are very, very hot on this. And I don't know whether any of them are listening to this talk. We can talk about it afterwards. So analgesics should also be given at regular intervals because you know that the pain is ongoing as long as in the first 48 hours, tissue healing is just starting, hasn't taken place yet. And so the patient will have pain, especially on movement. And so you need to give regular rather than PRN. The choice of analgesic is based on a ladder. The WHO ladder was initially invented for cancer pain, but we have modified it. In Malaysia, we use this to choose what drug to use based on their pain score, whether it's mild, moderate, or severe pain. And we put this in our guidelines for our Ministry of Health staff. So a mild pain, you can use paracetamol and NSAID, regular and PRN. And then moderate pain, again, you add a weak opioid like tramadol, and severe pain, obviously, you will add morphine. And if the patient is not taking orally, you will use it parenterally. And so we use this for any kind of acute pain, including postoperative pain. And we have another step called where we say you can refer to the acute pain service, which looks after these patients with severe pain. Choice of analgesia can also be based on type of surgery, minor, moderate, or major. And you can see this is more been advocated for patients undergoing day surgery, ambulatory surgery. So for minor surgery, you will use these techniques. For moderate surgery, so drugs as well as wound infiltration, as well as maybe a block. You can add in an opioid for moderate surgery. For minor surgery, you don't need opioid. And you could use a weak opioid. And obviously, for major surgery, you need to do something more. You need to use IV opioids as well as some blocks. So we go back to morphine. How can we deliver it? We can give it orally, IM, subcut, IV, continuous infusion, intermittent bolus, or patient controlled. You can do it epidurally or spinally. And the ones in bold here are the techniques that we most commonly use in the delivery of morphine or other opioids. Patient control analgesia and epidural analgesia, and that's what I'm going to talk about. Okay, we also, and before we talk about that, we want to talk about the concept of the analgesic corridor, which is the concentration of analgesic drug which achieves pain relief without adverse effects. So in this diagram, it is the part in gray. And if this is just to show you that if you give intermittent IM, you're going to get periods of time here and here and here where the patient may not have pain relief. And you may also get the patient going up into too high levels, which will give them serious adverse effects. Okay, so compared to PCA, the patient actually will, the beginning of the diagram is a little bit wrong. The patient will actually press until they come up to the analgesic corridor. And then they will maintain themselves at this level, because every time they have a bit more pain, they will press the button and push themselves up. So they maintain themselves at the lower end of the analgesic corridor. And if they have more pain, like when they're going to move, they can actually press some more and push their plasma levels a bit higher. So patient control analgesia is actually better. Okay, so it's post-op pain, I think commonly used, very commonly used. But you need a computerized pump. And I think I don't need to go into details. And usually we just give a demand and a lockout interval. Okay, and we usually use morphine, but nowadays we also use oxycodone and fentanyl. So it's effective. Patient likes it because patient is in control. The patient only uses as much as they require. So chances of overdose are lower. Okay, and so patient satisfaction is higher, but then you need additional equipment, additional training. Everybody needs to know how to set the machine, and you need to know how to troubleshoot. So there are some downsides as well. Okay, then you have regional anesthesia. I talked about epidural as well, and included in regional anesthesia is peripheral nerve blocks, which is becoming more popular. So regional anesthesia, neuraxial as well as peripheral. Neuraxial, you have epidurals and spinals, and I'm really spinal just to talk about, us using single shot morphine now when we give our spinal, especially for cesarean section, and we can achieve up to 24 hours of good post-operative pain relief with intrathecal morphine, a very small dose that doesn't give you the side effects that we used to worry about. Epidurals still, I think, commonly used, and usually, and the commonly used cocktail is fentanyl plus a local anesthetic, either ropivacaine and bupivacaine or levobupivacaine. We can use local alone or opioids alone, but that's not as efficacious as the mixture. So the advantages is that provides good analgesia with less systemic side effects and can be done in all ages. So there's the little baby here receiving epidural analgesia. But disadvantage is that you need to put it at the right place in order to achieve your block of the right dermatomes. You need the expertise, and it is invasive. Peripheral nerve blocks getting more and more popular, especially with ultrasound guided nowadays. Okay, so I am not so good at doing ultrasound guided, but I'm sure all of you are now. All the young generation know how to use these machines, and machines are really available much more freely now. Last time we had one machine in the whole theater. We have to fight for the machine, So you good for limb surgery, for orthopedic surgery. Okay, but we can also use field blocks, which can be used for thoracic or abdominal surgery. You can use it as a single shot local anesthetic or continuous infusion. And now they are adding all kinds of things to try to prolong the block. Like, so you have, obviously it's good because you block where you need to block only, and you can get very good analgesia, and you can even do your surgery under peripheral nerve block. But there's a learning curve, right? And then you need time. And sometimes the surgeon says, come on, I want to do my surgery. Why are you taking so long to do your block? And the patient cooperation is very important, right? Surgeon's cooperation, of course. If you do a single shot, the duration of analgesia is limited. So if you need longer analgesia, you have to add on other things, but usually you can supplement with oral analgesia by that time. And so we sometimes do continuous analgesia if we expect the requirement for analgesia to be more prolonged. But your catheter, it's always, everybody has their own best method of securing the catheter, right? Because otherwise its catheter may slip out, and that's the end of your block. So does it work? Yes, many studies done, and now, as I said, very, very popular. So this meta-analysis has shown that it does, whether single shot or continuous, provides superior post-op analgesia and fewer opioid-related side effects compared to opioid analgesia, which is quite obvious, isn't it now? But as I said, you do need a learning curve. You need the cooperation of patients. So you need, like this is an example from University Malaya of a patient information sheet. Okay, telling them what it is so that the patient can understand and can cooperate with you. And you need to recognize that there can be some complications like numbness, muscle weakness, which the patient needs to know about beforehand so that they won't worry about it, because it mostly will be temporary only. And you need to monitor to make sure that, especially if you're doing central neuraxial block, that you don't have any catastrophic event like an epidural abscess or epidural hematoma. Okay, so we do Bromage score regularly as part of our monitoring of patients on epidurals. Okay, then non-drug techniques. Remember, we always have non-drug techniques, and we always try to train our nurses to encourage the use of non-drug techniques. So you have the physical methods, the rest, ice, compression, elevation, which you use for acute injury related pain actually, and not so much for post-operative pain, but we can use ice for post-op pain as well. We can use TENS, we can use ultrasound, and you can use relaxation, music, imagery, distraction, and you can use methods like acupuncture, but you need some training, patient needs you need to have patients who are cooperative and open to the idea. And so there are many, many different factors. In Malaysia, we have something which we call our pain-free hospital program. And we advocate a multidisciplinary, multimodal approach to pain management, which includes all the different specialties, including traditional and complementary medicine, so massage and acupuncture, which we have actually the service in some of our Ministry of Health hospitals. So the next slide is just to show you that, in fact, we also promote multidisciplinary approach to acute postoperative pain, where we get the surgeons and the nurses and some of the medical students maybe who are in the ward to follow us when we do our acute pain rounds. Normally, in the past, just the APS doctor and nurse will go and see the patient, you know, and nobody else bothers about us because they know that we are going to look after the patient well, you know, but they don't really want to know. But we want everybody to be involved so that if the analgesia doesn't work so well, for example, the patient will be attended to sooner, and other people also understand what we are doing, and we don't have situations where we go to the ward and the surgeon has pulled out the epidural catheter. I'm sure you have experiences like that, where the surgeons say, oh, the patient cannot ambulate, the patient cannot PU because of your epidural, you know. So I see some of the faces that I can see are smiling, so I'm sure this resonates with you as well. It occurs definitely in Malaysia, and it must occur in Indonesia as well. So discussion and understanding of what we are doing, I think, is very important. So, I'm already more than 45 minutes. I just very quickly go through the fact that there are many guidelines available. Okay, so some of the guidelines available: American Pain Society guidelines in this publication. Okay, again, use of multimodal, combination of pharmacological and non-pharmacological for the treatment of pain with high quality evidence. Okay, you have this good book by Stefan Schuck and Pam McIntyre, which is a practical guide to acute pain management. Then you also have the Australian ANSCA. This one is the 4th edition. I'm sorry, now they have the 5th edition already, but I didn't get a picture of that. And it's free for you to download. So all the scientific evidence, it's very long though, it's a very thick book, but you can just read the recommendations. Then Malaysia, we have our pain management handbook, which is also available actually for you to download. I think, I'm not sure whether it's still available now because we're supposed to be updating it, but there's some technical issues. And then we have come up with pain as the 5th vital sign guidelines for doctors and nurses about how to manage patients in the hospital. This is all part of our pain-free program that you mentioned just now. International guidelines also. Prospect is interesting because it's procedure specific. Their take is that each different procedure have different ideal form of post-op analgesia. And so you can go to that and they will tell you about each of the different types of surgery. Okay, so evidence-based. So it's very good, and it's again available on the internet. Okay, so all these different types of surgery are covered, and if you're going to do any of them, you can go and see what they recommend based on the evidence. So for example, for total knee arthroscopy, they have assessment, and then you have all the different options: GA plus femoral nerve block, spinal with femoral nerve block, and then spinal with morphine. Okay, which is not recommended as the first choice because of greater potential for side effects. Okay, so they tell you the evidence, they tell you whether it's recommended or not recommended, and the different surgery will have a flow chart like this. So that's the end. I already used up my time, more than my time. We talked about acute post-op pain, which is actually common and unfortunately still not the best control that we can achieve. And why we are concerned about it is because not just because of the acute physiological events, but also the chronic condition, chronic pain that it can lead to if it's not well treated. The approach that we should take is multimodal, and we should use whatever guidelines that we like to use. But we should have actually protocols, standardized protocols, and your acute pain service should be set up by your department, anesthesiology, in your hospital. So with that, thank you very much for your attention, and I'm happy to take questions. Sorry, I took so long. I thought I will finish in 45 minutes.
No problem, Doctor. It is
But
such
it's
a good slide.
54 minutes.
You are just a little bit over the time. Thank you, Doctor, for your presentation. It is such great and well presented. Now we have come to the discussion session. First, we have a question from a Q&A section from our own teacher, Dr. John Francitepu, Fellow in Pain Management and Pain Management Consultant. May I read the Dr. John questions? Good afternoon, Doctor. I'm Dr. John from Medan. Very clear and great presentation. As you mentioned about descending modulation, in case of acute pain, adjuvant analgesia can be used that in acute case of pain, serotonin and norepinephrine are still sufficient or good enough. So, based on your experience, which adjuvant is the best for acute post-operative pain and prevent chronic post-operative pain as well? Is it gabapentinoids or SRI or SNRI?
Okay, thank you very much for the question.
Is the question clear, Doctor?
Yes. Can you hear me?
Yes.
Shall I stop my sharing? Wait, I stop sharing first so that we can see everybody. Okay. Thank you for your question. The short answer is actually we don't know. So the whole thing about descending modulation, yes, in theory, it should work, right? We should be able to use the anti-neuropathic agents, which are work on the serotonin and the noradrenaline pathways to block, basically to enhance inhibition. We are not just blocking the pain signals going up, but we are enhancing the descending inhibition. But in practice, as I mentioned briefly just now, they have tried to show that it works in preventing chronic post-surgical pain, because the theory is that it will reduce central sensitization, but they have not been consistent in showing this. And as I said, I think the problem is because we don't know what dose to use, when to start. Should we start much earlier? Or if we start much earlier, the patient doesn't have neuropathic pain. Is the patient going to get the side effects and not the benefits? You know, so there are all these considerations. How long are we going to continue? How big a dose are we going to use? You know, do we have to use anti-neuropathic agents for a patient with neuropathic pain? Normally we start at a lower dose, especially in our population, the non-Western population, who seem to be a bit more sensitive to these centrally acting drugs compared to the Westerners. And so, you know, if you use a low dose, it may not work. If you use a high dose, the patient will get knocked out, you know, too dopey. So how do you find the balance? I think we really haven't got the answer about what is the correct dose, how long, and how long should you continue, because your noxious stimulus is still going on, isn't it? You know, so do you continue as long as he has acute pain? Do you only continue? Do you continue after that as well? Is there any more central sensitization going on? We don't know. We really don't know the answer. But I would err on the, you know, the surgery that have a high incidence of chronic pain, like post thoracotomy. Open chole, now they don't do open cholecystectomy anymore. Maybe things like more of thoracotomy, you may want to add in, and spinal surgery. you may want to add in your gabapentinoids at a dose that you are comfortable to use. So I would use either 600 milligrams once a day or 300 milligrams twice a day as my dose of gabapentin to add to this, to add to your normal analgesic regime. But you also need to do things like regional anesthesia and things like that to prevent your central sensitization. Does that answer your question, Dr. John?
Thank you, Dr. Mary, for your answer. Excuse me, Doctor. Today, now we are joined by our very own teacher, Dr. John Francis Tepu. Excuse me, Doctor, are the answer clear? Do you have any more following question, Doctor?
Yes, thank you. Hello, Dr.
I cannot hear you.
How are you? I'm from Medan, and I think yes, Doctor. You can hear me?
Not very
hello?
clearly.
Hello, Doctor. Now we can hear you. Please.
Hello, Dr. Mary. You can hear me?
Now I can hear you, yes.
Okay. Thank you, Dr. Mary, for your answer. And honestly, your presentation is a great presentation and very clear for me. But my question is about the use of adjuvant for acute postoperative pain or prevent chronic postoperative pain.
You mentioned.
Honestly, I'm already used
Excuse me, Dr. John. We didn't hear the voice clearly, Doc.
Acute postoperative pain, and that is a good result actually. And I was read some. Yes, hello.
Hello, Doctor. Can you hear me clearly?
I think his connection is not very good, huh?
Unfortunately, yes, Doctor. Hello, Dr. John. Can you hear us clearly,
Yes,
Doc?
I think my connection is not good. So I'm sorry for this.
Yeah,
Hello?
maybe you can type your further comments in the chat and then we can look at it. But I also wanted to mention, I forgot that you asked about SNRIs and SSRIs and tricyclics. I think that the studies on the use of adjuvants for post-op pain is more for in using pregabalin and gabapentin, especially pregabalin, and not so much with the SNRIs. The other thing is we do use them in patients who are higher risk of requiring high doses of morphine. So like the opioid tolerant patient, okay, patients who are drug users, opioid drug users, patients who are chronic cancer pain on long-term opioids, So those kind of patients, we may add in these adjuvants in order to try to reduce our use of morphine. But usually we also will add in things like ketamine. And sometimes if there's a risk, especially of acute neuropathic pain, we may add in the use of lignocaine as well. And there's also studies on dexamethasone. So, but all the studies are not, not very clearly showing us what exactly to do.
Thank you for your answer, Dr. Mary. Is there following question from Dr. John? Excuse me, Doctor.
Did he put in the chat?
Yes, yes. Okay. I think it's clear. Thank you, Dr. Mary.
Okay, you're welcome.
Thank you, Dr. John, for joining us today. We are very humbled to be joined by our very own teacher, Dr. John Francitapu. Now we would like to move on to the next question. Shall we? The next question is
Yes.
from our very own senior resident, Dr. M. Rizky Pratama. How long do we give post-operative analgesia, and what is parameter to us to see if the pain has reduced or resolved, and how to titrate the analgesic given?
Very good question, Dr. Pratama. I would say that you use the pain score and you use the function. Okay, so it has to be dual. You ask the patient the pain score, so you'll be documenting the pain score all along, okay? But you also have to see the function. Can the patient get up? Can the patient take a deep breath? Can the patient actually move? Okay, if the patient is just lying in bed and says, my pain score is 3, I don't need any more painkillers. My pain score is 3. But the patient refused to get up, refused to blow to do the spirometry for the lungs, then there's something wrong, you see. So we need to actually have both function as well as pain score. But in the normal patient, they will, when you encourage them to move, to use they will eventually say, okay, now I can move more comfortably. I don't need to press the button, for example, if they're on PCA. And PCA is very easy in a way that you will see them, say first day they use 50 milligrams of morphine, second day maybe a bit more, sometimes a bit more because they start mobilizing on day 2 only. Maybe 60, then it will come down to 40 and 20. For us, our cutoff point is 20. When they're 24 hours, so we monitor that 24-hour use of morphine when we use a PCA. When they are using less than 20 milligrams of morphine a day, then we think that they can come off. We can take off the PCA and we convert them to oral analgesia. So for epidural, a bit more difficult, but when they can move comfortably with the epidural, sometimes we will just stop. If it's usually not on the first post-op day, second or third post-op day, depending also on your experience with how long the wound healing takes place, you can stop your epidural infusion. Normally we give as continuous infusion, right? So we stop the infusion, but we keep the epidural in, and then we come back a few hours later to see how the patient, if the patient is still comfortable without the infusion, only on oral analgesics, then we can pull out the epidural. So if your question, I assume your question is about when do you stop your post-op technique, right? Your post-op analgesia technique, but we always continue paracetamol, NSAIDs if not contraindicated, and usually we step down to a weak opioid. So usually we use tramadol on a regular basis, and usually we will give the patient 5 days or 5 days of medication to take home, depending of course on which post-op day they are discharged. So one of the problems that occurred in the US with the use of opioids for post-op analgesia is that they were using strong opioids. They were discharging the patient on oxycodone. And so this is what led to what they call the opioid crisis, that, patients were being given 2 weeks, 3 weeks, a month worth of oxycodone to take home. And you know that the wound is going to heal much sooner than that, you don't need to be on it for so long, you know. So now they have reduced the maximum duration of opioid that they can prescribe post-op to 3 days, I think, or 5 days maybe. But in Malaysia, we hardly send patients home on strong opioids. Normally it's tramadol. So we are not so worried about dependence, but if we do have a bit of a worry about whether this patient, or if the patient has a chronic pain problem beforehand and is discharged on strong opioids, we always see the patient for follow-up in our pain clinic, maybe in 2 weeks, 3 weeks time, so that we can talk about weaning off the strong opioid. So that is about weaning. I didn't have time to talk about weaning, so thank you for this question.
Thank you very much, Doctor. Such a good answer. To answer the Dr. M. Rizky Pratama question, I think the answer is very clear. Now we have, thank you, Dr. Rizky, for the answer. Okay, now do we have any more questions from our participants? Okay, I think there are no more questions from our participants. Thank you very much, Dr. Mary Cardosa.
You're welcome. Thank you. Thank you for listening to me. I hope I didn't make it very boring. There's lots
such a
of things to
great
talk about.
presentation. Well presented, Doctor.
Okay, thank you very much. Thank you for the invitation.
Now we have come to the end of this international guest lecture. I would like to say thanks again to Dr. Mary Suma Cardosa and for all the audience for your active participation. Now the summary for what I can take from this lecture is pain, the 5 vital signs, is not always bad. It is also good, so people can protect themselves from injury, and acute pain must be treated so don't become severe and alter some physiological change, and treatment should be individualized. Plan preoperatively. The aim is not to necessarily eliminate pain. Multidisciplinary, adequate monitoring, and multimodal analgesia. That is what I can take from today's lecture. And now I would like to give the lecture again to Dr. Akmal. Thank you very much, Dr. Mary Cardosa. Dr. Akmal,
you.
Please take the forum.
Thank you, Dr. Rico. That's a nice and splendid presentation, Dr. Mary.
Thank you.
Can we ask a little more of your time to have a documentation? We will take the picture from our Zoom meeting.
Okay. Picture, must always have picture.
I would like to invite Dr. John. Can you please turn on your camera, Doctor?
Maybe Dr. John,
our very own teacher, to join this as panelist, Dr. John.
Oh, maybe Dr. John. Okay.
Okay.
Thank you, Doctor.
Okay, we will take the picture. Smile to the camera, Dr. Mary. We can the picture. 3, 2, 1. Again, we can take another pose, maybe. Okay, we take the picture. 3, 2, 1. Okay. Nice.
Thank you.
Thank you so much, Dr.
It's my
Mary.
pleasure.
Thank you once again. Thank you very much, Dr. Mary.
Thank you so much, Dr. Mary.
I hope you and your family are always in good health, Dr. Mary.
Thank you very much. Thank you. Bye-bye.
Bye. Okay, that's wrap up our international guest lecture today. Maybe we can meet again in another international guest lecture.
Sure. No problem.
Once again, thank you very much.
Bye-bye.
Bye-bye.
Terima kasih, Dokter.
Terima kasih, Sama.